Dr. Amy Brenner, and thank you for choosing our practice, Amy Brenner, MD and Associates. So patients come to us in the perimenopausal and menopausal time frames with a lot of symptoms, and you may be experiencing some or even all of these. Vasomotor symptoms like hot flashes and night sweats, not sleeping, fatigue, decreased libido, starting to gain some weight around the middle, mood issues, brain fog, maybe cold hands and feet, not being able to lose weight, and as you can imagine, the list keeps going on and on. We will look at what symptoms that you're presenting with, as well as your medical history and your family history, and decide what hormones or what aspects of hormones should be checked. Sometimes when patients come into us, they say they want their hormones checked, and they think that that's simply their sex steroids. Sex steroids includes the hormones estrogen, progesterone, and testosterone. And sex steroids are definitely a really important aspect of hormone balance, but it's not the only aspect of hormone balance. So when we look at the pillars of hormones, we want to balance your sex steroids. We want to look at your thyroid. We want to look at insulin levels, which insulin is a hormone that regulates blood sugar. Adrenal hormones is another aspect of hormone balance. And last but not least, growth hormone is another aspect of hormone balance. Now, growth hormone, first of all, we don't prescribe growth hormone. And if we do things to optimize your own growth hormone, that's really the cherry on top and something that we do for patients who are really far along on their healthcare journey. I mentioned adrenals. There are some blood tests such as DHEA and pregnenolone where we can check via serum or blood test. It's not the best way to assess your adrenal status, but it's easy to test via blood. So we usually like to start with that. Insulin is another hormone that if it's too high can cause people to hold on to weight, not being able to lose weight, and cause other symptoms as well. Typically, we initially get an assessment of if there's a problem with insulin by looking at a blood test called your hemoglobin A1C, which is the average of your blood sugar over the past 3 months. Later on, we may choose with your provider to look specifically at your insulin levels, but that's a conversation for another day. For most patients, depending on what symptoms, we may do a full thyroid panel, which looks at your TSH, free T3, free T4, and some antibodies if they're present in your body that may signify that you may have a subset of thyroid issues such as Hashimoto's or Graves' disease. And last but not least is your sex steroids, estrogen and progesterone and testosterone. So based on your symptoms and history, we may look at some or all of those hormones. But the rest of this video is really going to focus on sex steroids, estrogen, progesterone, and testosterone. And the reason why we're doing this video is there's just so many options as it relates to, first of all, if we should replace these hormones, how to replace them, the options, the different routes. And there's lots of controversy and differing opinions on should we replace them, for how long we should replace them, or not just replace them, but by optimizing them and that type of thing. Unfortunately, sex steroids or female hormones, estrogen, progesterone, and testosterone, have just gotten a bad rap over the years. And hormones have kind of been villainized, if you will. And a lot of patients think that hormones are kind of bad for their health. So I want to go into a little detail of, well, where did this come from? Where this kind of bad news with hormone therapy came from is with a study called the Women's Health Initiative, or you may hear us call it the WHI. So this was probably one of the biggest studies, meaning it enrolled a lot of women, and it was a randomized controlled trial where women didn't know if they were receiving a drug or if they were receiving a placebo. So it was randomized and controlled in that way, and then looked at what happened over time. So there were 3 groups of women in this WHI study that was published in 2002. There was women who were given Premarin. Now, Premarin is a group of horse estrogens that's taken in an oral or pill form. There was a group of women who were given Premarin plus medroxyprogesterone acetate, and that drug together was called Prempro. And then another group was the placebo group. So what happened to these groups? Women who took Premarin, or this oral horse estrogen, had an increase in blood clots, which is clots in the legs or lungs, heart attacks, and strokes. And we have since learned that really all oral estrogen increases the risk of getting blood clots. So that really wasn't a surprise. We also learned that the estrogen-only arm of the study, their bones did better, they had a lower risk of colon cancer, and they actually had a lower risk of breast cancer. But we don't hear that on the news, do we? The Prempro group is what really went like wildfire in the press. Women who were taking Prempro, which again is a synthetic progestin, not progesterone, and we'll talk about that later, but a synthetic progestin along with the oral horse estrogen, this drug showed an increased risk of breast cancer and also the increased risk of heart attacks, stroke, and blood clots compared to the placebo group. So when this study came out, millions of women decided to stop their hormone therapy, which was really a shame. Over the next decade, the Women's Health Initiative data was reanalyzed and said that when hormones are started within the first 10 years of menopause, probably because it's before a lot of disease states start, so before heart disease started, before dementia started, that type of thing, that hormones therapy, actually the potential risks, even with Prempro, were lower than not taking hormones, and that the benefits of Prempro actually outweighed the risks for those women within the first 10 years of menopause. But after 10 years of menopause, that's when the risks really started to increase. So that's where the guidelines from an organization called NAMS, the North American Menopause Society, has actually changed over the course of the years. You'll hear me talk later about NAMS and what their guidelines stand for, which brings me to my next point, which is this: what is the standard of care? Now, the standard of care is actually a legal definition. That means what a similarly qualified physician would do in certain circumstances. And that leads me to, in general, kind of the difference between traditional medicine and what you'll see in our practice. In our practice, we like to call ourselves integrative practitioners because we still do traditional medicine and pap smears, and I still do surgery and hysterectomies. So we still absolutely do an element of traditional medicine. But we also do a lot of functional medicine where we try to get to the root cause of what's going on and see if that's the cause of what your symptoms are. So in traditional medicine, most physicians will exclusively use only FDA-approved hormone therapies, such as Premarin, Prempro, or other synthetic hormones. There are some bioidentical hormones that are FDA approved, more about that later. But in our practice, we really like to look at your symptoms and try to get to the root cause. And there are hundreds of thousands of doctors worldwide who have been trained similarly to us, who like to treat based on symptoms and optimize different levels of hormones. So when we talk about standard of care, it really depends on the training of the individual physician. What is bioidentical hormone therapy? What that means is that the chemical structure is exactly the same as the chemical structure that your body makes. The biggest confusion that I see is with this is as it relates to progesterone. Even in the medical literature, I'll be reading a journal and they will be calling a drug a progesterone when in fact it is a progestin or a progestogen. And what that means is that these progestogens or progestins, they're kind of like our own natural bioidentical progesterone, but the molecule has been changed just a little bit that now it can be patented and FDA approved and be available in a commercially available pharmacy. Again, bioidentical means it's the exact same as what your body makes. Now I'd like to talk specifically about what each individual hormone does: estrogen, progesterone, and testosterone. We're going to start with progesterone because that's actually the first hormone that starts to decline in your late 30s, early 40s. So when progesterone starts to decline, but estrogen remains the same, in that perimenopause time period, you actually end up with a situation called estrogen dominance because of that. There's a lot of confusion about progesterone versus progestins in the medical literature. In fact, a lot of times I'll read a study and it will say, hormones cause this bad thing. And then you actually read through the text of it and they'll reference progesterone. But when you really look at what drug was used, a synthetic progestin was given. So there's a lot of confusion about that. Synthetic progestins have just been shown over and over to, number one, increase the risk of breast cancer. Synthetic progestins also increase the risk of clotting. Natural progesterone does not increase the risk of clotting and actually has been shown to decrease the risk of breast cancer in many studies. Synthetic progestin actually has some harmful metabolic effects. It is harmful to your blood cholesterol levels, insulin levels, and glucose levels. Natural progesterone actually has a favorable effect on some aspects of the lipid panel, and it doesn't have those negative effects on blood glucose. So, in summary, natural progesterone has been shown in many studies actually to be breast protective and in some studies to reduce the risk of breast cancer and decrease the mammographic density on mammograms. Both synthetic progestins and progesterone do protect the endometrium, which is the lining of the uterus, from the stimulatory effects of estrogen. I already mentioned that natural progesterone is more cardioprotective than synthetic progestins. The other benefit of natural progesterone relates to your neurologic system. There are progesterone receptors on all of your neural cells and has shown your nerve cells or neuron cells to actually promote growth. And it also helps protect something called the myelin sheath, which is the covering on all of our nerves. So therefore, there is some evidence in the literature that progesterone can help with some neurodegenerative disorders, as well as be helpful in traumatic brain injury and decreasing inflammation in the brain. What are some of the symptoms of progesterone deficiency? Probably the most common one is sleep difficulties. Other symptoms can be mood issues, breast tenderness, headaches, and heavy bleeding. The side effects of taking progesterone are actually pretty rare. Once in a while, somebody will be really sensitive to the sedative type effects of progesterone, and they'll just feel a little drowsy in the morning after taking them. Most of our patients have experienced improvements in their sleep and sleep much soundly after taking a progesterone pill. Progesterone typically is given in a pill form or a capsule form. And the reason is there's just so much more data in the medical literature with oral progesterone, particularly as it relates to protecting the uterus from the stimulatory effects of estrogen. Progesterone is also available in a cream or also available in a sublingual type of capsule. There's some controversy as it relates to if a woman has had a hysterectomy, do they need to take progesterone? And where this comes from is doctors were taught this again by the pharmaceutical industry, is that when women were taking Premarin, they were shown to have an increased risk of uterine cancer because Premarin, along with other estrogens, stimulate the lining of the uterus to grow. So decades after Premarin was on the market, women were having an increased risk of uterine cancer due to the stimulatory nature of estrogens on the uterus. So this wasn't good. So the company developed Prempro. And so then women who still had a uterus got Prempro. But I've already told you the negative effects of synthetic progestins and Prempro. So therefore, women who have had a hysterectomy didn't have to undergo the negative effects of Prempro. Unfortunately, that thinking has jumped to natural progesterone. And in our opinion, that's actually a mistake because there are progesterone receptors throughout our entire body. And as I mentioned, there are some benefits of having progesterone throughout your whole body. Next, I'm going to talk about estrogens. Estrogens are actually the last hormone to decline, and typically we don't give estrogen to our patients until they are menopausal. Menopause is an interesting word. The true definition of it means a woman who has not had a menstrual period for over a year. Menopause is not a off-on type of thing or something that happens overnight. Typically, hormones just start to decline from the late 30s into the 40s and even into the 50s. So it's not something of an all or none phenomenon. There are 3 different estrogens in our body. The most potent one and the one that's the most studied is estradiol. The other estrogen is estriol. Now, there is no FDA-approved estriol for women. Estriol has been shown to be more breast friendly and improve breast health and also urogenital health, and can also help with some vasomotor symptoms, which are hot flashes and night sweats. Estrone is kind of what's been considered the bad estrogen, or that can be stimulatory on breast tissue. So we typically aren't giving estrone when we're giving estrogens to women. Estrogen comes in a lot of different forms to get into your body. It can be taken in an oral form. Now, we don't do that in our practice because when estrogen is taken orally, it goes through your liver and can increase the risk of clotting. The other methods that don't go through your liver, such as patches, creams, gels, or pellets, do not stimulate the clotting factors in your liver. NAMS, which is the North American Menopause Society, which releases guidelines for physicians, most of their recommendations relate to using conjugated equine estrogens or horse estrogens. I'm going to go off on a tangent a little bit and talk about guidelines because you'll read about these guidelines in our consent form. Guidelines are just that. They're kind of recommendations given by a panel of physicians based on their opinion on review of some of the literature. Guidelines are not law, and so they can be taken with a grain of salt, if you will. But I do want to make you aware of the guidelines, and the NAMS guidelines are written out in detail about hormone therapy in the consent form that you will be given. So what are some of the symptoms of estrogen deficiency? Certainly there's too many to list because we would be going on and on because estrogen has hundreds of functions in the body. But the typical things that estrogen does when it's deficient can lead to hot flashes, night sweats, decreased energy, increased weight, decreased libido, vaginal dryness, pain with sex, wrinkles on the face, or decreased skin laxity. Some of the side effects of taking estrogen, we mentioned with oral estrogen, can increase the risk of blood clots in your body. So blood clots in your legs or lungs, which are pulmonary emboli, strokes, or clots to your heart, which are heart attacks. If you do have fibroids or polyps, those are just growths of certain tissues in your uterus, and they have estrogen receptors on them. So when we give estrogen, if somebody has a fibroid or a polyp, it could cause those structures to bleed. And sometimes it's actually a good thing because it's actually brought to our attention and they're diagnosed. Side effects of estrogen can include, the most common one is bleeding and breast tenderness. The last hormone we're going to talk about is testosterone. Not because it's the least important, but because it has the most controversy associated with it. Surprisingly, women actually have more testosterone in their body than estrogen, and there are testosterone receptors all over our body. Unfortunately, when we give testosterone, it's actually a controlled substance, meaning it's in the same category of drugs of pain medicines like morphine. When we give testosterone, we don't give it orally because of the risk of blood clotting. There used to be an FDA-approved synthetic testosterone called methyl testosterone, but when that was taken, it actually caused liver toxicity, so we don't give that. So testosterone has to be given in a non-oral form. So it can be either given as a cream, a subcutaneous injection, or even a pellet. Unfortunately, there are no FDA-approved options for women. So testosterone, if it's appropriate for you, has to be given through a compounding pharmacy. There's a lot of controversies over the use of testosterone in women, and there's a lot more information listed in the consent form, so I really encourage you to read and study that. Testosterone, when women are deficient or have some testosterone insufficiency, it can present with a lot of symptoms. Probably the one you're most familiar with is decreased libido, decreased sexual desire. It can also interfere with your overall quality of life. In general, I referred to testosterone as just that feel-good hormone because of its overall effect on your overall well-being. The health of bones can suffer. Women can become tired, have mood issues, inability to maintain muscle, and muscle has really been shown to be called the currency of health. So when we lose muscle with age, that medical term has been called sarcopenia. It can interfere with memory and cause brain fog, as well as alter your distribution of fat, and be one of the reasons why women start to put on abdominal fat. Now, testosterone is not a weight loss drug, and it certainly is not used in this capacity in our practice, but indirectly, because it helps build muscle and reduces visceral fat, when somebody are doing all the other things that we look at in our functional medicine tree, indirectly, sometimes testosterone can have a beneficial effect on body composition. What are some of the side effects of testosterone? Again, sometimes you'll read in the literature that they'll include what is related to oral testosterone, but non-oral testosterone has not been shown to have an adverse effect on blood glucose, blood pressure, or lipids. The side effects that we do typically see with testosterone is we know that testosterone naturally stimulates your bone marrow to make more red blood cells. So we keep an eye on your red blood cells for patients who are on testosterone therapy. The other side effects of testosterone therapy are really dose related, and I call them more nuisance side effects. So the side effects of having too much testosterone can be acne, oily skin, unwanted hair, or even a high libido. Because it brings blood flow to the pelvis and can be shown to help with vaginal dryness or increasing the sensitivity, it does bring blood flow to the clitoris. So if somebody has too much testosterone on board, that clitoris can become a little swollen. In the literature, you'll read that testosterone can cause hair loss, That isn't something that we typically see in our practice because hair loss is a whole other separate discussion, and there are, many etiologies for female hair loss. What about testosterone in the breast? Although long-term data on long-term use of testosterone in breast cancer isn't known, and we absolutely need more studies of testosterone, there are a lot of studies in the medical literature that are referenced in the consent form that shows that testosterone can be beneficial to breast health. Like I mentioned, there's a lot of controversies about using testosterone. The NAMS guidelines state that testosterone should only be used in postmenopausal women with decreased libido. They do report that testosterone has been shown to have effects on muscle, lean body mass, mood, energy, bone, but that they are recommending its use to only postmenopausal women with decreased libido when everything else has already been tried, such as removing antidepressants, seeing a counselor, sexual counseling, etc. On the other hand, there's another expert opinion that the guidelines for both NAMS and this other expert opinion are listed in detail in the consent form, and I encourage you to read all of those. Sometimes people come to us and say, well, my other doctor didn't want to check my hormone levels. And quite honestly, I actually don't have that much of a problem with it because there really is no scientific evidence that a single level of your hormones equates to giving you any type of hormone. And there's nothing in the literature that says your hormone level when you're taking a particular hormone should be this. So why do we do it? We like to get a baseline level to just help us as a guide. And we like to follow your hormone levels because we have an idea of a range of where patients seem to do best. We also want to know that your body is actually absorbing these hormones and that your hormone levels do increase when we're giving you these types of hormones. NAMS in their guidelines say that the testosterone level specifically should not be in supraphysiologic ranges, meaning it should be in the normal reference range. Unfortunately, there's no scientific evidence for that expert opinion. Most of hormone therapy and dosing of it isn't based on your lab value, like it is when we're treating anemia, or like it is when physicians are treating diabetes and we're following your hemoglobin A1C. It's a lot more complicated than that. So although we do look at your hormone levels, it's just one piece of the puzzle because your hormone levels change throughout the day, throughout the time of the month, in relation to when you last took your hormones, whether you checked your hormones at the peak or at the trough. And it's just a lot more complicated than that. So we look at that, but more importantly, what we look at is your response to the therapy of, is this therapy working? Are you having any side effects? Do we need to increase or decrease the dose based on your response to therapy? So what are the delivery methods if with shared decision making that you and the provider that you're seeing decide that hormone therapy may be right for you? We talked about oral medications. That really isn't something that we do in our practice for oral estrogen or testosterone. When we're giving progesterone, we do typically give it as an oral pill because of the profound data with oral progesterone. Estrogen can be given as a cream or a pellet from a compounding pharmacy. Testosterone from a compounding pharmacy can be given as a pellet that goes under the skin and combined either by itself or with estrogen. It can also be combined in a cream, or testosterone can be given as a subcutaneous injection. There are some FDA-approved hormone therapies. There are FDA-approved options for menopause that are non-hormonal, such as antidepressants have been shown to help with hot flashes. Now they have their own set of side effects. There are some non-bioidentical FDA approved options, but quite honestly, that doesn't make sense to me in this day and age when bioidentical therapy is available. There are some FDA approved bioidentical hormones for estrogen and progesterone. There are no FDA approved or commercially available options for testosterone. So we will discuss this with you in more detail when we look at your individual history and choices. So now that you've heard all of the background, and quite honestly, if you paid attention, you probably know more about hormone therapy than actually a lot of physicians do.